Welcome to the Home of Medicine and welcome back to season 2 of this podcast. Today I am joined by
Ben Lovell. Hi, I'm an acute medical consultant working in London in the UK. Thanks so much for having me back. Long time no see.
No, it's been, thank you so much for coming back. I'm Amy Burbridge. I'm a consultant in acute and general medicine in the West Midlands in the United Kingdom. And on today's episode, Ben is going to present a case to me with hopefully some good learning points for all of you listeners out there. Over to you, Ben.
I'm going to tell you about a patient I saw whilst the consultant on take in acute medicine a little while ago. This is the story of an 81-year-old man who comes in to A&E and eventually to me on the medical take after having an episode, well, let's call it a funny turn, whilst in the pub and was conveyed in by ambulance. I just want to give you a bit of background to when I saw this patient. It was in a day shift when we were frantically busy and my hospital had already sent me a text. I don't know if your hospital ever texts you, but mine likes to text me when I'm on call saying, we have no beds, we have 30 patients waiting for beds in A&E. Please discharge as many people as possible. Please avoid admission in all cases possible. So it's one of those shifts. And my medical team, the medical reg and the other doctors on the team were working flat out. And we were getting a lot of referrals. And I don't know if you ever do this, but I was looking at the take list thinking, are there any easy wins that I, as a consultant, can go in, clerk and simultaneously post-take, and it's done. And that's one less for everyone else to see. And I was scanning and I saw this patient, referred in, 81-year-old, collapse in pub, now completely back to normal, no injury detected. Query home. I thought I'll go in and I'll see this patient. Maybe I can do a nice bit of admission avoidance. So I saw the gentleman himself. He was in the room with his wife. And the story was thus. He was in the pub. He'd had 3 pints of beer in the pub, stood up to go home and put his coat on when he fell backwards. And as he went backwards, he said he struck the back of his head on the wall, not hard, but it was a good tap. He did not lose consciousness either before or after this fall and this head strike. And he says he has no warning. He thinks he literally stumbled backwards, although he's not entirely sure. And his wife, who was there, says she saw him stand up, she saw him go to put his coat on, and then at the corner of her eye, she saw him just keel backwards and then sort of slump against the wall, hit his head, slump to the floor, but did not appear to lose consciousness at any point. No epileptic movements at any point. She said he went very pale, but he was always responding and talking to her all the way through. And then afterwards, she thought, in her words, he was a bit spacey, and someone else, the pub, had called an ambulance, and an ambulance arrived and conveyed him into A&E. And our fantastic colleagues in the emergency department had already done a very good workup. They'd done all of his bloods, which were normal, except for on his venous blood gas, they noticed a lactate of 3.9. But every other blood parameter was completely fine. And they'd done a CT scan of his head and his neck because there was a head trauma. And this is a patient who takes rivaroxaban. And the CT head and neck was normal. Looking at his past medical history, the only thing of relevance was his atrial fibrillation, for which he takes rivaroxaban for anticoagulation and 2.5 of bisoprolol for rate control. And he was an ex-smoker. He drank about 10 pints over a week. And 3 pints in one sitting was not a large amount of alcohol, but he would never drink more than that in one go. So I went to see him. So I guess that's a natural pause point. Anything you're thinking about here, or does it all so far so straightforward?
I think the way that you've presented it to me is that nice complete package, isn't it? Where you've got a very clear presenting complaint. The blood investigations have already been done. You've obviously had a CT head and neck, which was normal, which is fantastic. We want to ensure that there is no intracranial bleed or subdural hemorrhage because of the DOAC, but also because of the head injury. And you've done the VBG, which is the isolated elevated lactate level. What was his glucose level?
His glucose level was normal. He's not a diabetic, and it came up on the VBG as 6.1.
Okay, so that's good. Has anything like this ever happened before?
No, he's never fallen or lost consciousness before. He's never had a funny turn or a collapse, if you want to call it that, like this before. And this was confirmed by his wife, who was very, very switched on and knew a lot about what was going on with him.
Okay. What I tend to ask patients and their relatives in this situation is, did anybody film it? And I know that sounds a bit weird, because people always say, I didn't film it. And I'm like, oh, because if you film it, you can then, it's, you know, often the description of something and actually what it looks like can be very different. And certainly that's something that I do say to people who have loss of consciousnesses or regular faints or seizure activity is maybe next time get somebody to film it if they're around.
Yeah.
But nobody filmed it. And you said that it was a bit spacey. When you saw him, was he still a little bit spaced out, or
Yeah.
was he back to complete normality?
That's a good question. So just to touch on what you've just said, if you can't get something filmed, and when I'm getting my collateral history from a witness from a collapse, whenever I notice when I say, tell me exactly what happened, people tend to go, oh, I don't know, it was such a, because they're terrified. What a terrifying thing to happen. It's one of your, you know, nearest and dearest suddenly collapses in an ambulance and people around, and they don't tend to remember. So I tend to ask a few prompt questions. And I always say, if I say, did they lose consciousness, my number one, very often they say, I don't know, I don't know. So I always say, what were their eyes doing? Eyes open or eyes closed? Eyes fixed, open but glazed, eyes rolled back, eyes screwed shut, because that really gives me a bit of a pointer about whether or not I think they had a true loss of consciousness, or whether this was epileptiform or syncopal. And I always say, what color did they go? And this is absolutely no evidence. This is my own personal anecdotal library of cases here. But people who've had a syncopal attack, the watchers tend to say they went completely stark white, absolutely pale, almost blue. They were so pale. And were they covered in sweat? Actually, they did get covered in sweat. And with their eyes open, they were sort of half open, but not fixed. And I find that those trigger questions tend to give you more of a richer picture from a witness, rather than saying, tell me what happened, because everything tends to be a bit of a blur. So that's my little point there.
And what about the direction of fall? So if somebody falls backwards or forwards or sideways, do you read anything into that?
I never really thought about that one before. I think if you suddenly lose tone, muscular tone, you tend to crumple, don't you? Although I have seen a couple of spectacular feints who've gone down like a felled tree, i.e. completely rigid, but they just swung perpendicularly down and struck the floor. I guess it's useful if they sort of slumped and grabbed hold of something. So they were holding onto the door frame or the back of the sofa. That implies to me that it's they're still maintaining some level of awareness. Whereas if they suddenly was like a puppet, someone cut their strings and they just hit the floor, that does sound like true syncope to me, which can be pretty violent to watch. They can literally go, the lights go out and down they go all of a sudden. Do you have any tips for direction of fall?
Not really. I think it's anecdotally, isn't it? One of those things that you hear, I think it's passed down from generation to generation, is if you faint, you tend to faint forwards. Whereas if it's a seizure activity, you tend to fall backwards. But but then you talk to somebody else and they say the opposite. So I don't think there's any evidence base that we can read into that, to be honest. I just wondered if that, you know, sometimes if you see a lot of falls, a lot of feints or funny turns, people have different ideas, but I have to say it's not something that I would probably put much weight on anyway when I'm taking that history. Did he have any neurological symptoms? So had he complained of a headache, any visual disturbances, any speech abnormalities?
None before, during, or after. So I examined him. You asked me about this spacey. I mean, what a vague term, a little bit spacey. And it's hard to judge someone's baseline spaciness when you're meeting them. You're seeing them on a very bad day, you know, where they have been, you know, had a very scary event. They've been dragged in an ambulance, probably sat and waited for a very long time, missed a meal, missed a medication dose. By the time I see people on the tape, they tend to look a bit frazzled anyway. But I was trying to determine myself what this spaciness meant. And on examination, I'll tell you his examination findings. He was hemodynamically very stable. His blood pressure was 143/85. I stood him up and measured it again, and there wasn't a postural drop, because I thought, oh, this sounds a bit postural to me. His heart rate was 81 and in rate-controlled AF, as we already know. Saturations were 95%, and he was afebrile. He had no focal neurology on examination. What I did notice was that he seemed very, very tired. He had GCS 15, but then when I'd stop and speak to his wife for a while, I noticed he would drift off a little bit to sleep. He had been waiting in A&E for many, many hours, though. He He had 3 pints of alcohol on board, and he woke up very easily. I woke him and he go, yeah, and he was completely oriented when he woke up. I did a 4 AT score on him to see if there was a subtle delirium, and he got a score of 1. And he got the score of 1 because counting the months backwards, he got to August and got fed up. And you have to get to July or June or something. You have to do 7 months. Otherwise, you get the point. So I couldn't really score. Otherwise, alertness, his AMT4 was fine. And there was really no acute change. But yeah, I turned and talked to his wife. I looked back and he'd nodded off again. But then he'd wake up quite easily. And I thought, gosh, he's exhausted. He's had a long day. And I said to his wife, is he back to his normal self yet? And she said, to be honest, no. He's not normally this sleepy, and it's a bit grumpier, a bit more irritable than he usually is. But it's nothing. I'm happy to take him home, actually. I'd like to get him home, get him wrapped up into bed. He wants to go home, and I will be fine. And we have a good family to call, and we'll if there's a problem. Yeah. And that was my examination. Otherwise, cardiovascular, abdominal, and respiratory exam was all completely normal as well.
What about his pupils? Were they dilated? Were they pinpoint?
Equal and reactive. They were slightly small, but older adults tend to have very small pupils, certainly. But they were equal and reactive. No red flags there.
And also, if you're in an A&E where it's incredibly bright and there's lots of lights around, it's not unusual, is it, for the pupils to be a little bit smaller? Okay, so you've done an A to E assessment, which was absolutely fine. His blood pressure was fine, temperature, everything was absolutely normal. History-wise, socially, you said that he drinks 10 pints a week. Was he a smoker?
An ex-smoker.
Expert. And when did he stop smoking?
In his 60s, so 20 years ago.
Okay, so probably quite a significant pack-year history of smoking. However, he hadn't smoked for quite a while. Okay, you mentioned a VBG, and that his lactate was 3.9. What was his pH on that gas? Was that within normal limits?
Normal. So the pH was normal limits. Everything else on the VBG was normal. Just this isolated lactate of, what did I say? It was 3.9. Yeah, 3.9. Yeah. In the context of, gosh, I don't know. What do we blame lactates on in medicine to try and make ourselves feel better? We say, oh, he's a bit dehydrated, or they're a bit stressed. They've had some salbutamol. I couldn't find anything to blame it on, really.
Okay, and his glucose is normal. So when I see a lactate like that, I always think to myself, okay, you've got a high lactate because either you are producing too much or you are not excreting enough. So was there a problem with the kidneys or the lungs? And it didn't sound like there was, because he said all the bloods were normal and the gas was fine and he wasn't acidotic. So was he producing too much lactate? So was there any signs of infection? Was there any signs of sepsis? And actually, though he was apyrexial, he was a little bit irritable, but bloods were normal, white cell count was normal. Did he have a CRP?
CRP was less than 0.6, which is unrecordable in our trust. So no, he did not.
So very low. So there's nothing to suggest infection. Occasionally, alcohol can increase your lactate level, but I often tend to see that in people with chronic high alcohol intake, and I've often seen lactate levels in the 15 to 16. So 3.9, it wouldn't worry me, and it's certainly everything that you've told me. I'd be thinking, do you know what? He can go home. We've done everything we can. I don't really have a diagnosis. I guess in these situations, as an acute physician, I try to think, I need to rule out serious causes. Am I happy that I've ruled out a serious cause of this gentleman's collapse? So have I ruled out cardiac ischemia or a arrhythmia? Well, we know he's got IF. That's nothing to change there. Scanned his head, and there was nothing on the CT head. We've done blood tests, which are normal. His gas is okay, apart from the lactate. The bloods, all completely normal. So if I'm happy that we've ruled out anything really serious, then actually I probably would, given the situation, send him home with some safety netting and say, if it happens again, please come back and see us. Or if things don't improve, you get worse, please come back and see us. And maybe watch out for, any faints, any dizziness, any irritability, any increasing spaciness that you suggested.
Yeah, and I think that's an absolutely reasonable thing to do. We've talked a lot before on this podcast about how sending people home, how that decision comes about, and everything points towards him being able to go home. For what it's worth, I asked the nurse, can we just repeat that VBG again? And about 4 hours later, it was 2.2, which is just the limit of normal. So it was coming down. So the badness was going away. Now, for him, again, I went out and went back in again, and he was asleep. We were desperate for beds, and I admitted him for observation. I just wanted a few more hours, and I am not afraid to discharge patients. As you said, you made a very rational argument for sending him home. And I had said, look, I'm just going to admit him just for a bit more observation, because something was just a bit funny. I don't know if it was a sleepiness. I don't know if it was an isolated lactate. I don't know if it was the wife saying he isn't his normal self. If he literally fell over, he should be his normal self. And I don't know what it was that was speaking to me. Anyway, I admitted him. 3 hours later, emergency buzzer went off. And we all ran to his bedside, and this patient was in bed. His wife was by him. He was having a generalized tonic-clonic seizure, which lasted for about 4 minutes. The crash call went out. He self-terminated spontaneously without us giving any benzos. And post-ictally, his GCS was 5. Again, his pupils were equal and reactive. And I thought, oh my gosh, now he's bled into his head. He's anticoagulated. He had a head injury a while ago. Something's popped and he's bleeding. We couldn't detect any unequal pupils or a dent hemiparesis at the bedside, but his GCS was 5. He was actually intubated on the ward by the anaesthetists and taken back down to the scanner and had another CT scan, which again was normal, no intracerebral hemorrhage at all or intracranial bleeding. And he was taken to ITU, fully tubed. And I followed his case up, and the next day he had an EEG, which showed ongoing epileptic activity. And so his working diagnosis flipped to, was he having seizures? And this was then, and when I saw him in a slightly post-ictal state, and that was actually the index presentation, not a fall at the pub. And when the dust was settling, from this sudden unexpected intubation and a cardiac arrest call on the ward, one of my doctors, one of my senior house officers said to me, how did you know to admit him that was going to happen? And the absolute honest answer was, I didn't. And it was sheer dumb luck that I admitted him and I didn't send him home, which was an absolutely reasonable thing to do with the evidence we had at the time. But I wanted to try and give a sensible answer. And I was saying, gosh, I don't know why. It was a little bit of collateral history from wife, a little bit of sleepy patient, a little bit of lactate maybe, and maybe a little bit of gut feeling that something was going to happen. But I can't put my finger on what that gut feeling was. And I can't claim this story as a win for me, as due to my wisdom as a consultant. I know exactly who to send home and who not to. It was literally luck. And there is another parallel universe where Ben did send him home, and that man arrested at home, and they probably had a very poor outcome. And I guess I wanted to talk about this case just to show that we, as consultants, we're not wise oracles who know exactly who's going to tear or not. Sometimes we are just lucky that we made the right call, and the patient's even luckier that we did make the right call. And sometimes, even in retrospect, there is still a really strong argument for doing the other decision. I.e., imagine if I'd sent him home, he'd arrested, and there was a horrible outcome for him, and there was an investigation. The investigation, I would still have to write my statement, and my statement would still say, I realize now that something bad happened to him, but in hindsight, I wouldn't have done anything differently. It was still a decent clinical decision to make with the information at the time to discharge him. Even now I know that he went home, this happened. It was completely unpredictable. And I think, especially when you're more junior in the health system, you don't know that this is an absolutely reasonable thing to say. And you assume that you're going to get in big trouble. And you aren't, because all we want to know is, did you make a decent decision based on the available data at the time? And if I'd sent him home, I think I would have a decent rationale for having done so. He had an unforeseeable tragic event. Luckily for me and luckily for him, we have saved all of this drama because he was in the right place and actually did well. So there you go. What do you think?
So first of all, I think I want to take a couple of steps back. So you mentioned quite a few times during that you felt this was due to luck. Now, I actually think you're doing yourself a disservice, because actually you made that decision based on years of clinical experience, the knowledge that you've attained, the fact that his VBG was slightly abnormal, and your gut instinct, your gestalt. So actually that is not luck. Take some credit for this, Ben. I think that is your clinical experience. And sometimes you just get you in yourself get a weird feeling and you're like, this just doesn't feel right. I don't know what it is. There is something not right about this. And I do think that comes with experience. And it's very difficult to describe how you develop that. Can you teach somebody to have gut feeling? I don't know. And I guess this is where a lot of clinical reasoning comes in. Can you teach somebody to have that gut instinct? What do you think?
I think it's, well, we're talking about what, the Greeks call it phronesis, experiential wisdom, learning by having done it. I guess I don't think you can, but I think the next best thing you can do is talk about your own experience like we're doing now. And maybe there's a bit of a proxy, it goes in someone else's bank of past cases, even by proxy, and they're able to draw on it maybe. I have no evidence to back it up. I'm just thinking out loud. But I think us talking about cases like this, and especially when we're talking about when we say this is a gut instinct, I get it might be frustrating to hear saying, stop saying that, be specific. How did you know? Well, how do you know the answer? But saying it was a gut instinct and maybe trying our best to reflect and pull out what was calling to us in the story, that was calling upon our gut. Maybe that will help other people be more aware of it in their daily practice. So I mean, that's why I think it's great that we talk about cases like this when we get things right and also when we get things wrong.
Yeah, I completely agree. And I just want to share a quick story about gut instinct. So it was a couple of weeks before Christmas. So it was about a couple of months ago now. And my acute medical trainee saw a patient in the same day emergency care department. And the patient had presented with a sore throat. He was a gentleman, he was in his 80s, had a sore throat, a bit of a fever, and nothing else of note really. So my trainee went and saw the gentleman, and for some reason I will never know why or understand why he did this, but he assessed the patient and he thought, something's not right here. Something doesn't feel right in the neck. On examination, I can't see anything, but something's not right. And he spoke to ENT. And I went up to them, why have you spoke to ENT? Like, they're not going to come down here, are they? And they did. They were fantastic. And they came down and they did a nase endoscopy on the ward. And I was like, what are they wheeling on the ward? And it was a nase endoscope. I was like, wow, I've never seen this before happen on our unit. And they did a nase endoscopy and they found a very large parotid tumour. And I said to my registrar, I don't get it. You need to tell me why you did that. And he said, my gut instinct told me something wasn't right. And I was like, but what wasn't right? Because I said I wouldn't have done that. I would have saw this man, I would have looked in his throat and gone, there's nothing wrong with you, you can go home. And again, it made me really realize that something in my training, maybe he'd seen something before, maybe, he was looking at his hindsight, maybe he'd seen somebody before with a parotid tumor. I haven't. And it just, I kept saying to him, tell me why you did it. And he was like, I just did. And it's very hard sometimes to put into words what your gut instinct is. It just is a feeling. And you can't explain where that feeling came from. It's just there.
No, I agree. And there's something, it's about time, it's a longitudinal development. Our training program in the UK is slightly longer than other places. And a lot of the argument for that is you need to just see a lot of patients before you can get your CCT and be a consultant, an expert. You need to see the numbers. And since we don't want to work you insane 100-hour weeks anymore, thank goodness for that, we had to extend the programs to get you the numbers. And I understand completely the arguments for and against it and the resistance to it. And but there's something to be said for just banking numbers, just seeing case after case after case. And even if you think there's nothing to be learned from a barn door, a straightforward case, you're building something internally. You're building schemas, scripts, they call it in cognitive psychology, archetypes in your head, so that when you do see something, even if you don't say it explicitly to yourself, there's sort of a subconscious, I've seen something like this before. And that can guide you in clinical road, i.e. I know what tests we need to do, but also into the less clinical, the more non-clinical side of things, like whether this patient can go home or come in, should we be worried or not? I've been teaching junior doctors in the UK for many, many years now. Whenever I ask SHOs who are about to be registrars, what's the biggest thing that you're worried about being the reg? And one of the things they say is, I'm terrified of, how do you know when someone can go home? How do you know? And these are very, very bright people at the apex of their clinical training. They've done all the exams. They know more clinical medicine than me. And the answer to that is once you've seen 1,000 patients, then you'll start to know. We don't get it all right all the time, but you'll start to know.
Yeah,
It's fascinating to hear, but it's true.
Yeah, I completely. It is a bit of a numbers game, isn't it? And the more patients that you see and the more exposure you get, your confidence does grow. But we all make mistakes, and we all send people home maybe we shouldn't have sent home. We maybe admit people we maybe shouldn't have admitted, and that's how you learn from that as well. So you learn from those admissions and those discharges that maybe you should or shouldn't have done. And I think every patient I see. So I did a bit of a very large ward round this morning that seemed to take me forever, and I don't really know why it took a long time. Sometimes these things just happen, and at every patient I was saying to the doctor with me case, so what can we take away from that case today? Because every case we see, there is something to take away, even if it's something small. So I had a patient who took an overdose of unifilin today, and it was okay, let's look at tox base. Let's have a look at the key thing that we need to look out for. And one of the key factors of unifilin overdose is hypokalemia. And they can become hypokalemic very quickly. And actually, sometimes this hypokalemia can drop so rapidly that it can cause cardiac arrhythmias and cardiac arrest. I'd forgotten that. Did I ever know that? And that was something that I again learned today and will take away and won't forget. And we had lots of other people on the ward, and I was like, okay, this is your one learning fact from today. Unifilin or aminophylline overdose can cause hypokalemia. So it was just little things like that. And it's about banking that in that little knowledge base that we've got and then taking that forward.
It all goes in the bank.
All goes in the bank, although I'm still overdrawn, I think, in mine. I don't think I'll never have enough information in there. Okay, so key takeaway points then from today's episode, Ben.
I guess if I was going to say a key takeaway point, if you're not sure if someone has a delirium or not, the 4AT test is very easy to do. You don't need special training. It's way easier than the AMTS that I was taught to do as a junior doctor. I couldn't remember the 10 questions, let alone if they got the 10 answers wrong. And it is it's a validated scoring system for picking up more subtle and hypoactive delirium that you might have missed before. So although my guy only scored 1, I do find it actually quite useful. And I guess the other learning point would be something along the lines of the value of a witness or a collateral, especially in a case like this where the patient themselves checked out of the universe for a couple of seconds and they don't know what happened during that collapse or whatever it was. And someone else can give you a very, very good account of what happened. And also, if I didn't have the wife telling me he isn't his normal self, doctor, he's not normally this sleepy, then I would have sent him home, in all honesty. So that really was a clincher in this case as well. Now, I'm absolutely not saying that every time a relative says, hey, they're not the normal selves, you admit the patient. But in this, it's just part of all of the evidence and the reasoning I was adducing in the case to make a decision. So that was super useful.
Yeah, absolutely. And just to recap on the 4AT test then, for anybody who hasn't heard of it, it's an assessment test for delirium and cognitive impairment. We'll use it quite a lot in the United Kingdom, and it's broken down into 4 areas, 4AT, so alertness, AMT4, so age, what's your date of birth, what's your place, what are you in the hospital, what building are you in and what year is it, and then attention, so that's, you mentioned month, can you count months backwards, and is this acute changes or does it fluctuate? And what I will do is I will put this on the podcast website so you can all have a look at it and learn it and take that forward with you. Excellent. And also we talked about gestalt and that gut instinct, which I think we're all honing on a day-to-day basis, is we're really building on that gut instinct. Thank you so much, Ben. As ever, I've taken away loads of things again, so every day is a school day. And out to everybody out there, thank you very much for listening. And if you want to listen to any more podcasts, we've got season 1 is out there and available on Apple, on Spotify and on Google. And if you want to do any more learning, head to the EFIM Academy. Thanks for listening. Goodbye.
Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.